Hi everyone. Today I'm going to be going through a tutorial on imaging simple congenital heart disease. And the keyword here is simple, so hopefully we'll cover the majority of congenital heart lesions that you will see in your workplace and in your working career. Some things we will discuss are the bicuspid aortic valve, right heart valves, shunts, ASDs, VSDs in particular, RV pressure and volume overload, and other notes and tips on how to image these patients. Some of the learning objectives that we'll cover: one, defining the essential images and measurements for bicuspid aortic valve, measure pulmonary and tricuspid regurgitation, differentiate ASDs from VSDs, and discerning RV volume and RV pressure overload. So we'll start off with the bicuspid aortic valve. This is the most common congenital heart disease, and it's often undiagnosed until adulthood. So we will be seeing a lot of these patients and commonly diagnosing them for the first time. These valves can cause aortic stenosis and regurgitation, with over 50% of these patients requiring valve replacement. And the most common presentation of these patients is an incidental systolic murmur. These patients also have an increased risk of endocarditis, around 30 times greater risk than the normal person. And bicuspid aortic valve is also associated with aortopathies. Some of the other things that it's associated with are left ventricular hypertrophy, aortic dilatation, like I said, aortic coarctation, and aortic stenosis or regurgitation. Here are some different types of bicuspid aortic valve. So we'll start with type 0. So this is the true bicuspid valve, where there is only 2 leaflets. Type 1, this is the most common bicuspid aortic valve. And this is where there's a fusion or a conjoint area called a raphe in the valve. And type 2, this is fusion of more than 2 cusps. So there's functionally a unicuspid valve. So we'll go through some images now. Usually you may have an idea straight away in the parasternal long axis whether the patient have bicuspid aortic valve or not. So some of the features you should see is a typical skipping rope appearance on the left side here. And then on the right side, you may also see a doming of the leaflets. One other key feature that you should be able to appreciate here is the different lengths of the non-coronary cusp and the right coronary cusp. Here are some more features in the parasternal short axis. So this is a type 1 bicuspid aortic valve with a fusion of the non and right coronary cusp. And in this video, you can see this is the most common type. So this is also type 1, but there's a raphe or a fusion of the right and left coronary cusp. It is also important to note that when diagnosing bicuspid aortic valves, we diagnose this in systole and not in diastole. As you can see in this picture, in diastole, there are 3 cusps visible. However, in systole, when it opens up, you can see that it's clearly a bicuspid aortic valve. This is different for a very rare congenital aortic valve, which is called a quadcuspid aortic valve, where there's 4 leaflets, and that's usually diagnosed in diastole. And here's a last video on a 3D true bicuspid valve with 1 leaflet up the top and only one leaflet down the bottom. So now we'll move on to pulmonary stenosis. So isolated pulmonary stenosis is found in about 8 to 10% of patients with congenital heart disease, and is caused by dysplastic thickened and or tethered leaflets. And the stenotic valve can also often be unicuspid, bicuspid, or tricuspid. And the stenosis can also be classified as valvular, subvalvular, or supravalvular. So below the valve or above the valve. And pulmonary stenosis is often associated with other congenital heart disease, such as tetralogy of Fallot. So you can see here in this color compare image that there's flow turbulence or flow acceleration at this pulmonary valve in this pulmonary artery, and this is a subvalvular pulmonary stenosis. And then the gradients, we use the same as aortic valve, so this is about 3.3 meters per second, so this would be moderate pulmonary stenosis. Some echo features of pulmonary stenosis that we need to be aware of. So in this first panel, you can see that there's a very thickened and hypertrophied right ventricle. You can see in this video on the top right, the pulmonary valve is very thickened. When we put the color on, you can see that there's some obvious flow acceleration or turbulence at the valve level. And when we do the continuous wave Doppler, you can see that the velocities are 4.2 meters per second. So this is severe pulmonary stenosis. In these patients, we can do one of two things: a valve replacement or a balloon valvuloplasty. And this is determined by the patient's age, size, location of narrowing, and other coexisting congenital heart disease. In the case of a balloon valvuloplasty, these patients can often be left with significant pulmonary regurgitation, and this causes over time right ventricular dilatation due to volume overload. So we need to assess the amount or the severity of the pulmonary regurgitation. As you can see, there's a significant amount of pulmonary regurgitation there. Other methods to assess pulmonary regurgitation or right heart dilatation is through the continuous wave Doppler of the tricuspid regurgitation. And we can do that by looking at the density and the shape of the CW Doppler signal. Usually a more severe TR, you get a denser signal, and a mild TR, you get a faint signal. Also, the shape of the Doppler signal can give us an indication of severity. So the more severe the TR, the more triangular, or what we call a V cutoff sign, due to rapid equalization in pressure. And a non-severe TR would have a more parabolic profile. Another thing that you can measure is using color Doppler and measuring the vena contracta. Now I'll go through shunts, and we'll first go through ASDs. There are 4 different types of ASDs. The secundum ASD is the most common, 70% of patients. Primum ASDs, which is 20%, sinus venosus, and then there's 2 types, the SVC and IVC type, and then the coronary sinus. The last 2 are probably very rare, and you may or may not see them. ASDs make up approximately 10% of all congenital heart defects. They may present for the first time in adulthood. It's the 3rd most common type of congenital heart defect, and most importantly, they cause left to right shunt at the atrial level, and this causes right heart enlargement due to volume overload. So you can see here the different locations of different ASDs. So some of the echo features of ASDs. So sometimes you'll have patients come in for a routine echo and they'll have an image similar to this. This is your first image. You can see that clearly there's a dilated right ventricle, and they might not have any typical signs or clinical symptoms of it, but you should always suspect that there's an ASD if you ever see this on the initial picture. You can see here there's a bit of flattening of the left ventricular septum in systole, and then this is due to volume overload, which I'll talk about later. You can see here there's dilatation of the pulmonary artery. And then you can see here clearly there's dilated right heart. So for the secundum ASD, we can best appreciate it in the parasternal short axis view or the subcostal view. But in this case, we can see clearly there's a bit of a dropout or defect here. When we put the color on, we can see that there's a clear red jet going through the atrial septum. One thing we tried to figure out on our echo study is this length and the size of different rims or tissues. And this is very important because the cardiologist can use this to plan for any closure devices. If there is not enough tissue, they'll be unable to have a closure device and maybe needing heart surgery to correct or to patch up the defect. So in this view, you can see that they have the retroaortic rim and the posterior rim in this view. ASDs can also be seen very clearly in subcostal view, as you can see here. A clear red jet up here. So the tissues and the rims that you can see here, this is the superior tissue rim and then the inferior tissue rim. And this is another example of a secondum ASD. So now we'll move on to primum ASD. So this is often almost always associated with AV canal defect. It usually happens just inferior or superior, however you want to look at the heart orientation, below the ventricular septum near the top of the atrial septum. So you can see here, there's a nice defect just below the AV valves. And you can see in these patients, you have usually significant mitral regurgitation. And this is due to, they usually have a coexisting cleft anterior mitral leaflet. So you can see in these patients, it's often associated with an inlet VSD as well. And this is just a video of a primum ASD with a cleft mitral valve leaflet that I did a few years ago. You can see a nice cleft there. When we put the color on, you can see a clear significant mitral regurgitation from that area. Now we'll move on to sinus venosus ASD. So sinus venosus ASD is when there is a defect occurring near the vena cava. So you can see here, this is the left atrium, and then this is the SVC and then IVC here. So you can see the defect is right very close to the SVC side, and then this would be the IVC type of sinus venosus ASD. So I tried to replicate this picture over here. You can see there's a clear defect here, as you can see here, labeled. And when we put the color on, you can see a nice shunt going in there. This view is the subcostal bicable view, where you have to rotate the probe from a subcostal 4-chamber clockwise to about 4 or 5 o'clock. So move on to the next one. This is very rare, the coronary sinus ASD. This is also called an unroofed coronary sinus. So usually you can see that they have a dilated coronary sinus, and you can appreciate that on the parasternal long axis usually. And then this is where there's a shunt between the left atrium and then the coronary sinus. You can see here the coronary sinus is dilated and a clear shunt of blood from the left atrium flowing into the coronary sinus. So left to right shunt. So I added this slide in for people who might not know how they close ASDs. So watch this video. Usually they put a catheter through the ASD and then they deploy the device on usually the left side of the heart and then bring it back to the right side of the heart. And this valve will then endothelialize over time and the shunt will be closed, hopefully. You can see here, there's a clear ASD, there's the deployment of the device, and then this is the end of the device deployment. So now I'll move on to VSDs. So there are 4 different types of VSDs: perimembranous, muscular, inlet, and supracrystal. So these account for approximately 20% of all congenital heart disease, and they're usually diagnosed in childhood with a loud murmur. These shunts cause left to right shunting at the ventricular level, and this causes left heart enlargement initially and then eventually right heart enlargement. And the reason is because the VSDs cause an increased pressure and volume load on the RV and pulmonary vascular bed. And this causes increased pulmonary blood flow and increased pulmonary return to the left side of the heart. We also need to classify the VSDs when we find them to be either restrictive, which are typically small defects, lower with velocities higher than 4 meters per second, and non-restrictive VSDs, which are larger defects, which usually have a lower velocity of lower than 4 meters per second. And then you can see the different locations of the VSDs. So you have the supracrystal, which is usually just inferior to the pulmonary valve, a perimembranous VSD here, inlet VSD here, and the muscular VSD near the mid to apical segments of the heart. So we'll talk about perimembranous VSD first. So you can see here, I have an image of roughly where the VSDs should occur on the particular image that is shown. So you can see here there's an obvious defect here flowing from near the LVOT area all the way into the right ventricle, which is the left to right shunt. And then it can only therefore be one of these green or yellow, which is a perimembranous, or a doubly committed subarterial, which is a supracrystal VSD. So then you would then move on to the parasternal short axis of the aortic valve level and try to differentiate which of the VSDs it is. So as you can see in this example, the shunt is occurring between the 9 and 12 o'clock area. This is typical of a perimembranous VSD. The velocities through the VSD is 2 meters per second. So this is a non-restrictive perimembranous VSD. So we move on to the muscular VSD. These usually occur, but not always, near the mid to apical segments. So you can see here, there's a flow near the apex of the heart, apical septum of the heart, and then this can only be associated with muscular VSDs. And here is another example. So in this patient, there's 2 different muscular VSDs happening. The velocities through them are 4.6 meters per second. So this would be 2 muscular VSDs that are restrictive. So move on to the supracrystal VSD. So as you can see, this is very similar to the perimembranous VSD. As you can see, you can see the shunt happening in the LVOT area of the parasternal long axis, same area as the perimembranous. However, when you get to the parasternal short axis aortic valve level, you can see that the shunt is actually occurring between the 12 and 3 o'clock or even 2 o'clock section of the aortic valve. And therefore, this VSD would be a supracrystal VSD. And then lastly, the inlet VSD. So like I said, this VSD is associated with a primum ASD or AV canal defect. And then typically, you can see the defect in the mid segment of the LV septum. And then you can typically see it in the apical four-chamber view as well, just above the AV valves. And like I said, they will usually have some sort of mitral cleft as well as maybe a primum ASD, and it will be associated with AV canal defects. One shunt that I will also talk about is the patent ductus arteriosus. So this is around 5 to 10% of all congenital heart disease, and this is where there's a connection between the aorta and the pulmonary artery. This shunt causes left to right shunting at the great vessel level and causes left heart enlargement initially, and then eventually right heart enlargement, just like VSDs. And then we also classify this to be either restrictive or non-restrictive. So you can see here is the aorta, so the oxygenated blood, and then there's a connection from the aorta to the pulmonary arteries. So what does it look like? So you can see here, this is a parasternal RV outflow long axis view of the pulmonary artery. It's very, very important that we always try to put this color box tall towards this area of the pulmonary artery, near the left pulmonary artery branch, to see if there is any patent ductus arteriosus. So you can see there's a continuous flow coming from the patent ductus arteriosus back into the main pulmonary artery, as you can see with the CW Doppler. This is another example. This is in the suprasternal view. However, this is actually a modified suprasternal view called the ductal view, which is when we put the probe in the suprasternal view and then move it slightly inferior and left lateral on the patient towards the first intercostal space. And then we can see that this is the descending aorta, and then there's a continuous shunt through into the pulmonary artery. And then this is a typical patent ductus arteriosus continuous Doppler, but for a non-restrictive PDA. The velocities are lower than 4 meters per second, so it's only 1.5 meters per second compared with restrictive PDA here. Now, quickly go through RV pressure and RV volume overload. So with patients who have a ASD or a VSD, after the left heart is dilated, it will affect the right side. You will get pressure and volume overload. So for an ASD, you would usually get a volume overload, then a pressure overload. For RV volume overload, you will usually see a flattening of the interventricular septum in end diastole. And this is because in end diastole, that's when the pressure in the LV is at its least. So you can see here, in N diastole, it's got the flattening of the septum. In N systole, when there's the greatest amount of pressure in the left ventricle, the LV pressure is greater than the RV pressure, and it goes back to a circular shape. However, in RV pressure overload, usually you have a flattened septum throughout the cardiac cycle. However, it is more pronounced in N systole, as you can see in this example. In systole, it's the most flattened. You can have, obviously, a combination of RV pressure and volume overload, where you have extensive flattening of the ventricular septum throughout both cardiac systole and diastole. So some of the other matters or notes and tips that I can give you before you start a congenital heart patient. Some things you can do beforehand. You can read the past echo reports, review previous images if possible, and then if you don't understand the initial pathology of the congenital heart disease, try to figure out what has happened, if they have had any surgical interventions as well. Also, things to remember for the valves and ventricles. Tricuspid valve always follows the morphological right ventricle. So if you ever have transposition of the great arteries or anything like that, the valve always follows the ventricle. So the mitral valve will then also always follow the morphological left ventricle. Some other features that we can help identify which ventricle is which. The RV has coarse trabeculations and it always has a moderator band. So if you can identify these structures, then you can have an idea of which ventricle is which. LV has a fine trabeculations and two distinct papillary muscles. One other thing is the tricuspid valve has 3 leaflets while the mitral valve has 2 leaflets. If you can get a good image of those 2 valves, you can also figure out which is the right and left ventricle. In terms of reporting, be careful not to exclude anything. For example, if you don't see an ASD, don't exclude that there's no intracardiac shunts, because you can easily miss a sinus venosus ASD or even a coronary sinus ASD. And it's important to remember that complex congenital heart disease needs to be managed at specialist centers, as they will often then require further imaging and CT, such as CT and MRI.